I'm Fevzi Shakir, consultant gynaecologist at the Royal Free Hospital, and I'll be talking about surgical management of endometriosis. And there may be specifics to each of your conditions and care that I may not cover in the surgical talk, as there are specific nuances that certain individuals will have, but hopefully I'll be able to provide a summary that will cover most aspects of surgery within endometriosis. So first of all, who really should have surgery for endometriosis? Most people should consider it if medical management, for instance, hasn't provided enough relief. So majority of people will have some sort of medical management in the form of painkillers or hormonal medication, and that may not have provided enough relief. So surgery may be considered in that instance. Sometimes a diagnosis is uncertain because we know that endometriosis can mimic other conditions, and so it may not be clear to your healthcare professional who's seeing you what exactly is going on and exactly what issues you may have. So surgery may be used for that instance to diagnose endometriosis and then be able to make a management plan. Some women we know present with difficulty conceiving, and we know that endometriosis can affect that, and I'll come on to that a little bit later on in the talk. And so treating endometriosis in those instances can be helpful in some individuals. And also some people understandably are very worried about progression of the disease, and of course treating endometriosis earlier will obviously negate that more complex surgical procedure that may be required later on if surgery is not performed earlier. Now, starting off with superficial endometriosis, which is what most patients will have, we know that about 85% and even higher of the patients with endometriosis will have superficial disease, meaning that it's not going deep into some of the surrounding pelvic organs. Generally, treatment for superficial endometriosis is laparoscopic, as it is for deep disease as well. So we do keyhole operations. And the advantage of the modern day keyhole operation is that the recovery is very quick, the incision sites are very small, we have good magnification, good cameras with high definition, so that we can see lesions in a lot more detail. And the advantage of it is that we don't only see it, but we can then treat it at the same time in the operation. Now, there's always a lot of controversy in the literature as to what's best. Do we ablate disease, which is basically burning or destroying the disease using a variety of devices that I'll come on to, or do you cut away the disease and excise it? This was actually going back to the 1970s, where a gynecologist, Harith Hasson, who was based in America, actually treated endometriosis just by burning the lesions, and he did that for about 28 patients back then, and found that of the patients that he treated, their pain symptoms got significantly better, and a lot of them actually fell pregnant, whereas before they were having difficulty conceiving. And that's where a lot of the treatment for endometriosis stemmed from. And since then, there's been a whole plethora of different ablative techniques. Now, actually, in the UK, in 1982, was the first place in the world, in Guildford, where they actually treated endometriosis using lasers in that particular unit. And the results from then showed that of the 63 patients that were enrolled in the trial, half had treatment with laser and half didn't have treatment. And of the half that had treatment with laser, this was a randomized controlled trial, it was found that at 6 months post-surgery, symptoms in the laser group were significantly better than those which didn't have surgery. So we knew that lasers and treatment of endometriosis using that modality did work for the patients. Some of you may have seen different devices that can be used, and I'll just briefly mention some of them. So one of them that can mimic laser is helium, slightly different energy modality, but essentially does the same thing, and it's proven to be safe in some of the studies that have been performed. Another more modern day variant is using plasma energy. Again, very similar to the laser in terms of some of its properties. And again, it's concluded that it's safe, but there's no real long-term randomized controlled trial on all of these devices. It's mainly extrapolated from the laser data. Now, some of the current evidence looking at treatment for endometriosis is based on some of the Cochrane reviews, and Cochrane is a body which looks at all the data out in the scientific literature, mainly high-level randomized controlled trials, and tries to put them all together to deduce what's the best thing to do, combining all the studies together. And the latest edition of that was published last year. And what is definitely known is that laparoscopic surgery does increase viable intrauterine pregnancy rates compared to diagnostic laparoscopy alone. So if you have endometriosis and you treat it, your chances of viable intrauterine pregnancy rates do increase compared to diagnostic laparoscopy alone. What's still unclear, and that's been unclear for some time now, is what type of surgery is best to improve pain. And there are several different studies looking into that, but putting them all together, it's very difficult to deduce which one is the best one, because designing such studies is quite challenging, and no study is going to look at every single modality to see which is best. Looking at our own data, which I was involved in during my fellowship in Guildford, we looked at patients which were treated with ablation using laser, and also those which were excised. And we found that preoperatively, patients' pain scores were relatively high, as expected, when they've got endometriosis prior to surgery. And then after treatment with either laser or with excision, the pain symptoms did improve. It improved more so in the excision group than in the laser group. And a lot of newer studies are showing that excision probably has lower rates of pain compared to ablation alone. But again, looking at the Cochrane, all the results, it doesn't quite show that with all the studies put together. But you've got to obviously look at your own results as well, and some of the own data to deduce those conclusions. One thing I would mention for anyone going for surgery for endometriosis, as you can see from these graphs and from other studies as well, it does take some time. So this is the pain score on the y-axis, and on the x-axis is time. And you can see that at 6 months, you've got improvement of pain from a higher pain score to a lower pain score. Then as you go to a year and then to 3 years, you can see the pain scores going down. So you probably won't notice a significant difference till about 6 months post-operative, but then at 1 year, even better, and then further down the line, even more. So that's important to realize, that you may not necessarily get immediate relief, but things do improve as time goes on, probably due to the healing that can take some time to take place in the pelvis once all the disease has been excised. The other aspect I just want to briefly touch on is endometriomas, which can be part of your treatment of endometriosis, which are endometriotic cysts within the ovaries, and they can be on one side or both sides. But what's important is that if you've got a cyst picked up on scan, which looks like an endometrioma, there is likely to be pelvic endometriosis elsewhere in the pelvis and abdomen in approximately 50 to 80% of cases. Now, we do know that it can affect ovarian reserve sometimes when these cysts are treated, depending on the different techniques, and that's something you need to discuss individually with your surgeon as to how big the endometriomas are, how many you've got, and what the chances of that are. And then there's obviously different techniques to treat them. We tend to use stripping and draining in the UK, but some other countries are looking at sclerotherapy, where they inject some alcohol solution inside, but obviously that doesn't treat the rest of the pelvic endometriosis inside, and you have no biopsy with that technique either. But again, all of these have to be individualized to each of you. With deep disease, so that's disease where you have the endometriosis deeply penetrating some of the organs, such as the bowel or the bladder or any other distant site, they can be treated in 1 or 2 stages, with or without downregulation, usually with a medication like Zoladex, to calm the disease down before the next stage. And that again will depend on the center where you get treated and on surgeon and individual preference. Sometimes we have to place in stents for deep disease. So these are to protect the ureters from getting damaged during the surgery, or after surgery, sometimes you can get some swelling which can affect them as well. So they're a protective element that is sometimes used. If they stay in, they're sometimes removed in the outpatients or in a general anesthetic setting, again, depending on the individual. Sometimes we need to use a colorectal surgeon at the same time for management of deep disease because it can involve the bowel. And when we remove the endometriosis from the bowel, we sometimes shave it off, but sometimes some individuals may require a portion of the bowel to be removed and joined back together again. Again, because of modern day techniques, we're able to do nerve sparing procedures where we can preserve the nerves supplying the bladder, bowel, and vagina. And if someone's family is complete, they're at the end of their journey of endometriosis and it's accepting to them, they may opt to remove their womb, tubes, and ovaries because endometriosis may also be present in them. And we know that from some of the studies. But again, that has to be accepting and appropriate for that particular patient. You can see the data from our work on deep disease as well, which we published some time ago. And you can see that when we do surgery for deep disease with a bowel surgeon, the pain scores for each of the different parameters, painful intercourse, painful bowel movements, chronic pain, and painful periods, are all improved, probably slightly faster than the superficial disease because you've probably got more impact from adhesions and fibrosis, which is immediately relieved compared to the superficial disease. And that again continues at up to 12 months. And again, this graph shows that if you opt to remove everything, if it's appropriate for you, compared to just removing the endometriosis alone, so endometriosis and removing the organs if appropriate and at that stage of your life, then that can improve symptoms further. And that's, like I said, because some individuals will have endometriosis in those organs as well. So really, in summary, surgery needs to be considered on an individual basis. We're all slightly different. We all have slightly different needs and wishes and different pathology. And endometriosis is such a variable condition that it really does need to be individualized. One thing doesn't fit everyone. It should really be performed by a team in an endometriosis center purely because these can be high-risk procedures in some instances, and it really needs to be by a team who are used to managing up to complex cases. Like I said, it's really important to bear in mind when you go for surgery, it can take 6 to 12 months afterwards to notice a significant difference. It won't always be straight away. And surgery, again, is not the answer all the time. We know that endometriosis can come back. We know that some nerves have been affected even despite surgery. Some pain may continue. And it has to be combined with other treatments afterwards to try and help the symptoms further. And we do know that surgery can help improve pregnancy rates, and the data seems to be quite strong with that. Thank you very much. I know that was a quick summary of everything, and it's something that we can talk for hours about based on individual circumstances. But hopefully that's provided a useful summary for superficial and deep disease and what to expect. Now, I know we've got some questions that came through, which I've got here, and I'll try to answer them in the remaining 5 minutes that I have. So the first question that came through is, why is endo a common condition amongst women and it being undetected for over 7 years or more of pain and suffering to be diagnosed? Well, One thing about endometriosis that we all know is it can mimic other conditions, and it can take some time for healthcare professionals and for individuals to think about endometriosis as a potential cause. And also scans sometimes can be normal, and therefore years pass by quite quickly before you actually referred to a healthcare professional which suspects that endometriosis may be the cause. But this is improving with more awareness, with events such as these, with more media and public awareness. So hopefully we're doing a lot of work to try and reduce this time frame, because 7 years is an unacceptable amount of time, and hopefully we'll see improvements over time. Why is this condition not known amongst health professionals? Some said it's normal to have painful periods. Again, a little bit of that relates to some of the points I mentioned in question 1, in that not all healthcare professionals will be experts in all aspects of gynecology and may not know all parts of gynecological presentations. And again, awareness, education, GP training, interprofessional training is something we're all doing. So hopefully we will be seeing these improve and the time improve. And hopefully things like it is normal to have painful periods and it's in your head will be something of in the past. But it will take some time to educate and for awareness to get round to every single person. Why can those experiencing early signs of endometriosis be ignored? Again, a lot of these questions are very similar themes which we're seeing, and a lot of the time, like I said, it's sometimes that it can mimic other conditions. So, you know, a urine tract infection may have symptoms very similar to endometriosis, and sometimes it might be passed off as something else, and other avenues may be explored before endometriosis is considered. But you know, if certain symptoms and signs are there, then endometriosis should be something that should be thought of. And again, hopefully that will improve with more education, awareness, both for the public and for healthcare professionals. What features make someone a likely candidate for surgery? Hopefully I've answered that within the talk in mentioning the different aspects of when surgery can be considered. If medical therapy is not helping, if the diagnosis is uncertain, if fertility is desired and the symptoms of endometriosis, those are some of the features which make someone more of a likely candidate for considering surgery. Why are some people advised to stay on the pill rather than have surgery? Again, it's a very individualized point to mention. So, you know, if someone's never had surgery, medical therapy is not working, and they have no significant risk factors for surgery, then surgery is something they can consider. Whereas if someone has had several operations in other specialties and they're a higher risk candidate for surgery, then on balance, they may not wish to undertake the high risk of surgery. So again, that's something that has to be individualized, but everyone should be offered surgery if appropriate and if other measures have not worked. Does age play, or whether someone wants children, play a factor in putting someone forward for surgery? Again, it's something that's individual. So if they've not, having difficulty conceiving, and they've got symptoms of endometriosis, then surgery should be considered in those instances. Does the number of surgeries play a factor in putting someone forward for surgery? Sometimes it can do. I mean, if endometriosis has been diagnosed and surgery has helped in the past, and there's suspected recurrence, then doing another procedure may be beneficial. But if there's not been any time, then if there's not been any benefit, then doing further surgery may not be the right thing. What are the risks, or any, of making endometriosis pain worse? Unlikely. unless there's been a significant complication during the surgery, or if it's complicated with adhesions afterwards, which can sometimes happen. And that can answer question 9 as well.